how do I understand what these functional neurological disorders are, and then kind of how do I treat those, just kind of from a broad perspective. And then our other presenters are going to get deeper into specific aspects of some of this. So first, I want to, over the next, 45, 50 minutes, kind of just define functional neurological disorder for everyone, make sure we're all on the same page for the rest of today. Talk a little bit about the etiology, so what causes this, and then talk about treatment as well. All right. So I always find it really important to make sure that we're all having the same kind of operational definitions. So when I have a topic like this, I always like to make sure that we all are using the same terms and on the same page there. And that's often challenging with functional neurological disorder because there are so many different names. So many different names. So you might hear this referred to as, like we're using today, functional neurological disorder. But for those of you who are trained back in the olden days, like I was, we used the term conversion disorder, and that's all I had ever really heard during, for example, my graduate training. But there's other terms floating around there too: functional neurological symptom disorder, dissociative neurological symptom disorder. And so because of all these different names, it's not uncommon for one practitioner of mental health or a medical doctor to use one term trying to refer or talk to somebody else, and they're not even really sure what that is. So we see lots of confusion with these names. What we're starting to see more of a move towards, especially over the last decade, is that most of the researchers in this area and a lot of clinicians now, especially globally, are using that term FND, functional neurological disorder. And so we're going to really kind of stick to that and use that for today, even though I'm going to talk about some of the other names that are associated with that. So if you're going out and looking at the research literature, for example, and you're on PubMed, you might need to type any of these things in there in order to access that research. So in the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association for quite a while now, we've seen that this collection of symptoms, this syndrome, has changed quite a bit since the very first DSM. And in the very first DSM, it was called conversion reaction. And as you all, I'm sure, know from your history, a lot of our conceptualizations at that time were very heavily psychoanalytic, psychodynamically kind of influenced. And so this idea of conversion was really about, I'm taking my psychological distress and I'm converting it into some sort of physical symptom, right? So it's a reaction, it's a conversion reaction. And then DSM-2 stayed the same way, same type of name. And then when the DSM-3 came out in 1980, it was changed to conversion disorder, sort of recognizing that it's not just, kind of a symptom or a temporary thing, but more of like a full-blown kind of psychological problem and disorder. They kept that conversion label, which is very highly charged, and we'll see that in a minute. Still kept that though, and kept that into DSM-4 when that came out in the 90s. And then in DSM-5, finally did a little bit of a change where it's called conversion disorder still, but they have a secondary name, which is what they've done when they start to switch these, right? Which is functional neurological symptom disorder, which is a mouthful, right? Like that's a lot. So if you just looked up functional neurological disorder in the DSM, you're not going to see a code for that. You have to put that symptom in the middle of the name, or go back to kind of what we would have been calling it, a long time ago, which is conversion disorder. Relatedly, if you are going and looking in the international classifications of disease, so the ICD-11, the newest edition of that, actually completely removed conversion from the name. And instead is calling this what we call FND, calling it dissociative neurological symptom disorder. So they don't even necessarily have the functional part in there, which was an interesting shift. And that kind of removal of conversion as a descriptor was very purposeful because they're trying to become very atheoretical, not trying to have these kind of leftover terms from theories that many people are not subscribing to nowadays. And so they took conversion completely out of there and instead have a bunch of subtypes of dissociative neurological symptom disorder based on what the primary or predominant symptom is. And you can see those there. That could be having visual disturbance, so blindness or partial blindness, auditory disturbance, where I feel like I can't hear, or I have maybe some tinnitus kind of symptoms, having excessive dizziness and kind of vertigo symptoms, non-epileptic seizures, having problems with your speech, with your walking, having weakness in a certain area, but also having things like movement disturbance, which Charles will talk a lot about, or cognitive symptom disturbance, so memory issues, things like that. So lots of different terms out there. And I just kind of want to get that out of the way first so that kind of what's happening. And in case you see these terms somewhere else, you can go, oh, okay, that's what we were learning about the other day. That's what we're calling functional neurological disorder. So most of us are probably going to be doing diagnostic work according to things like the DSM. So I wanted to make sure that we understood what kind of the criteria were for that before we got into the rest of everything today. So in the DSM-5 and the 5TR didn't change this at all. Your very first aspect for diagnosis is that you have to have one or more symptoms of altered voluntary motor or sensory function. So the voluntary part is pretty important there because it's altered voluntary, meaning I'm choosing to move these kinds of muscles, or sensory function. Now we'll see here in a minute some of the symptom type specifiers that kind of go with that one. But you only have to have one symptom. A lot of people will have more than one of these symptoms, though, just as a heads up. And then the second aspect of diagnosis is that your clinical findings show that there's not another recognized neurological or medical condition that's causing this. So in other words, I'm having what appear to be seizures, or I'm having paralysis, or I'm having blindness, but the physicians, the neurologists, they can't find anything to explain that, right? So there's not an explanation from a medical model of why are you having these symptoms. And these symptoms are also not better explained by another medical or mental disorder, right? So we're having these symptoms of altered voluntary motor or sensory function with nothing that anybody else can find that should be able to explain that, right? So I'm having kind of seizure, what appear to be seizures, but there's no seizure activity in the brain, right? I'm reporting being unable to see, and feeling, that my eyes aren't working properly. But when we do specific tests of that, they seem to be responding as they should. So there's no neurological or medical condition underlying that. This is not due to things like psychosis or schizophrenia, where you might have altered functioning because of that. And Finally, this is causing, just like any other mental health problem, clinically significant distress and impairment. And that could be, lots of different areas. Maybe it's only social, maybe it's only with work. In kids, we see school impairment a lot. So having some sort of impairment or some sort of problems there. Now that first criterion A, these kind of symptoms of voluntary motor or sensory function, in the DSM-5, they want you to specify what symptom type you're having. And you could have more than one, certainly, but you need to be able to specify at least one because that's part of the criteria. So weakness and paralysis. So this could be, my voluntary muscles are just not working like they think they should, or I'm completely paralyzed from a particular kind of muscle. We also see this one that's the specifier is with abnormal movement, and these could be tremors. These could be kind of dystonic movements. This could be like an abnormal gait or the way that you walk. These could also show up, as Charles is going to talk about next, as looking like tics or a tic disorder. They in the DSM-5, they also put with swallowing symptoms, where I'm having physical difficulty swallowing, but there's no physical reason for that. Speech disruption is another kind of symptom specifier, and that could be, my speech just changes, and it changes in a way that I'm not trying to change it. But it could even be like speech symptoms in terms of recognizing speech and understanding speech, like an aphasia, or production of speech. With seizure attacks and kind of seizure symptoms, that's another one which we'll talk quite a bit more about today with Lorna. We also see sensory loss, right? So maybe I'm not responding to sensory input like I should, or with special kind of sensory symptoms. So it's not necessarily that I lost this, but things are different, right? Like the way that I'm perceiving visual or olfactory or auditory information has changed in some fashion. And then the last one you see there is the with mixed symptoms. So that's where where you're having this with multiple kinds of symptoms. So the DSM criteria, wants you to specify what kind of symptom it is. And then it has two more specifiers as well. And the first one of those is kind of timeline, right? So is this more or less than 6 months of presentation? And then the second is there a identifiable psychological stressor preceding the development of these symptoms? And you could say that, either with or without there. For a number of people, there are, but there's also a very large number of people where there isn't a specific identifiable event. So Lorna, for example, is going to talk about, people who are having psychogenic non-epileptic seizures post-traumatic experience, but you could also have those without a traumatic experience. So that's the kind of the DSM diagnostic criteria. And I think it's important to kind of understand, like, why were these changes made? Why were the symptoms shifting a little bit? And mostly it was to have a more inclusionary diagnosis. Because you don't have to have an identifiable psychological stressor or an identifiable historic kind of event that occurred before this. You can diagnose this even if you don't know that. And that's not necessarily the case in prior versions of the DSM. So basically trying to say, like, hey, here's these neurological signs, right, that are specific to this problem. And that's really what we want to focus on, are those symptoms and those difficulties that people are experiencing. And the DSM also, in the kind of the explanatory material in it, really focused on a wider range of past events that could basically sensitize you to developing functional neurological disorder. And that could be things like, yes, physical trauma, but that could also be like a medical illness, or that could be some sort of physiological occurrence, like panic symptoms, um, where, hey, there's a lot of things that could predispose me towards developing these functional neurological symptoms. We're going to talk about etiology here in a minute, and you're going to see some more examples of that. One of the big reasons why they tried to kind of highlight that is that there's a lot of research now showing that kind of your ideas and your expectations about how you respond to different kinds of events, what we call these sensitizing events, really show a strong relationship with how I'm basically interpreting and predicting what kind of sensory and bodily focus changes I might have. As we'll see, a huge amount of work has shown that with functional neurological symptoms, people do kind of pay lots of attention to and evaluate their bodies and their sensory data that's coming into their bodies. And they do so in different ways than people who don't have an FND. And we'll see that here in a minute. So lots of changes, but that kind of gives you an idea, a little bit of an operational definition of here's what's happening. So common symptoms that we see in functional neurological disorder, these were kind of alluded to in the symptom specifiers, but I just kind of want to go over those again because there's a lot, right? Like you can have 10 or 15 or 20 people who would qualify for an FND diagnosis walk into your clinic, and they might all have very different symptoms, right? So their functional symptoms might all be very different, even if they still qualify for the same diagnosis. In that way, it's kind of like somebody with panic attacks, right? Where I can have tons of people come in, and because there's so many different kinds of panic attack symptoms, I can have, an infinite variety of panic attacks and kind of what they look like for individuals. Same thing with functional neurological disorder, right? Lots and lots of varied presentations. There are some that are much more common, and we'll talk about that, but can be really highly varied. So weakness and paralysis is one of the ones that we think about first. And this could be just one limb. This could be general weakness of the body. This could be a temporary paralysis of, again, a limb or part of a limb, or this could be a paralysis of an entire area of the body. So I've seen folks who had, for example, just a arm that kind of didn't work anymore and was paralyzed. I've seen people who couldn't walk anymore and had FND paralysis, right? But we also see other kinds of movement-related problems. So tremors kind of looking like an essential tremor, for those of you who are familiar with ETs, or difficulty walking, even though there's no neurological, indicators that they should have difficulty walking. And that could be just like shuffling feet. That could be kind of difficulty moving feet one towards the next. That could even be, impacted by things like loss of balance or feeling dizzy and vertigo. Those kinds of things are pretty common. I've seen quite a few folks who reported having lumps in their throat, like feeling like there's something in there, and then I'm constantly trying to swallow or get that kind of taken care of, which would often lead to problems then swallowing or being able to really keep much food down. And then we see very commonly one of these, and we'll talk a lot more about it later today, is the psychogenic non-epileptic seizures, or what used to be called pseudo seizures. And this is where, you appear to lose consciousness, you appear to shake and have what appears to be usually a grand mal type seizure from most people's perspectives. And that could be completely, falling on the ground, appearing non-responsive. Um, you can also just see episodes of non-responsiveness that would appear to be more similar to, for example, a petit mal seizure, where you're not seeing shaking necessarily, but you're just kind of spaced out, dissociated kind of thing. Um, I think we've all probably seen what dissociation looks like. It would look pretty similar to that. So these are the typical ones that we see that affect more kind of body movement and function of the body, right? But we also see ones that impact the senses, right? So that could be feeling like numbness or like losing a touch sensation. So someone touches me and I report like I don't feel that, like I don't have uh, a response to that. But this could also be speech problems. This could be like losing the ability to speak altogether. This could be having kind of slurred speech, just kind of slowing down. Um, those are the most common ones that we see. Um, Visually, you can see folks reporting seeing double, right? So when I look at everything is doubled up, and it's really difficult for me to then navigate the world. But you can also see blindness, right? So where I report not being able to see the world, despite vision tests again showing that things are normal. Um, Hearing problems are also pretty common. Um, so where I either like I just have trouble hearing, like things are muffled, or completely deaf, like I report not being able to hear anything at all. Not too uncommon. And then we see cognitive difficulties. So I'm having problems with my memory and remembering things. I'm having problems concentrating. But there's not, again, neurological or medical symptoms that are identifiable to say, hey, here's why you're having that. Right. So these are more the sensory based kinds of symptoms that we see. Now, the two most common subtypes that you're likely to encounter currently are what we call functional movement disorder and then psychogenic non-epileptic seizures. And so the functional movement disorder encompasses things like this appears to seem like a Tourette's diagnosis or tics, right? Or this looks like an essential tremor or shaking that you might see in something like another neurological disorder. But again, no evidence of that. And I'm not going to talk a ton about this because Charles is going to really go into this in detail. And then the psychogenic non-epileptic seizures, typically, like I had mentioned earlier, they resemble more of like a grand mal seizure, right? Where I seem to lose consciousness, my large voluntary muscles are contracting in various ways, and it looks very scary to people on the outside because it does appear to be um, like a mall, a grand mal seizure. So those are the most common subtypes that you'll see. Um, the kind of, I would say, sensory ones are more rare currently, for sure. That hasn't necessarily always been the case. Those are some of the ones that are more reported on kind of historically, but these are the ones you're more likely to encounter now. Epidemiologically, these are rare conditions. Our best current estimates is somewhere between 4 and 12 individuals per every 100,000 people. Um, so pretty rare, right? Like this is not a common thing that you encounter, um, which is one of the reasons why so many clinicians don't know much about it, right? Like if I'm not going to be seeing very many of these, I might not even recognize it when it does show up. It's a little higher in most of our estimates for the kind of the motor-based symptoms compared to something like the non-epileptic seizures. But it's a rare condition overall. It does seem to be more common in females. The estimates there are anywhere from 60 to 75% of your clients would be female. But it's out there for sure, and especially if you're in larger areas or you're in areas where um, the population density is high, like you will see these folks. Functionally, this is a very, very impacting problem. What we see is that when we compare folks who have these functional neurological disorders, like the motor disorders, to people who have Parkinson's or who have essential tremors or tics or Tourette's, we actually see very similar levels of disability and decreases in physical quality of life. And we actually see worse mental health quality in these folks, even if they're phenomenologically appearing pretty similar. So without treatment, we don't seem to have very good prognosis. So in other words, this isn't something that just kind of naturally remits or remits in most people. Our long-term studies that have looked at this have seen that about 40% of folks have either similar or worse outcomes up to 7 years after the onset of those symptoms. So again, for most folks, this is not something that's just going to naturally go away without some sort of intervention or treatment. The big predictors of longer-term problems are older age and longer duration of symptoms, right? So the longer this goes on, the worse your overall outcomes are going to be, which is why early identification and then intervention becomes very, very important. Usually that longer duration of symptoms is related to being older. So lots and lots of functional impact, very, very negatively on people's lives. And then when we have one of these patients come in, our kind of first line recommendations is, well, you're having some of these symptoms, you need to go be checked out by a neurologist first, right? That is really the first thing you should do. Not just, oh, my family doctor told me to come in or my pediatrician told me to come in. You really do want to have a neurologist that you're comfortable referring to. And the research has repeatedly shown that even though this is a very rare problem, neurologists are very, very accurate at making a proper diagnosis and differentiating between, is this a neurological problem or is it a functional neurological disorder? And part of that is knowing, like, what are the actual signs and symptoms of these problems at a neurological way, as opposed to just more of a psychological way. And so when you make this referral to a neurologist, one of the key elements that they look at is the specifics of the symptoms you're experiencing. Because, for example, tics and Tourette's disorders present very differently than a functional movement disorder. Essential tremors presents very differently than a functional movement disorder. Having seizures that are epileptic seizures versus non-epileptic seizures, actually very, very different. I have a slide to illustrate that. One of the other big things that we see that differentiates neurological from functional neurological disorders is inconsistency and incongruence. So essentially what we are more likely to see in functional neurological disorder are symptom patterns changing over time or shifting in response to distraction. So you can basically test whether or not these symptoms are consistent or inconsistent in very specific ways, and we'll go into some of that later. But also the clinical picture just generally isn't consistent with what we know about these organic neurological problems. And again, I'm going to give you some examples of that here in a second with seizures. So very, very high, good diagnostic level here. Some of the things that also kind of help differentiate neurological versus functional are the sudden onset. So these tend to be functional neurological disorders tend to be relatively rapidly onset compared to other neurological problems. If you're able to like quickly and easily distract someone, they tend to decrease or go down. And the opposite, if you have people increase their attention on these functional symptoms, they tend to actually go back up. And then one of the other kind of major kind of clinical features of functional neurological disorders is high levels of excessive fatigue. So above and beyond what you would expect, generally speaking, or excessive kind of demonstration of effort. So seems like this is taking a lot out of you to be able to do these things. So I had mentioned that you can look at the problems, right, and see like, here's what you're presenting with. Does it match more of a picture of, for example, tics or more of a functional movement disorder? This is an example of things that you would see for seizures. So there's 3 columns up here. You can see that where certain kinds of symptoms are very common in psychogenic non-epileptic seizures, but they're very rare in epileptic seizures, or vice versa, common in epileptic, rare in non-epileptic. And then there's, they could be present in either one of these. So if you're not familiar with what an epileptic seizure looks like, you would see someone have a non-epileptic seizure and you would say they're having a seizure. But a neurologist who's really, really comfortable with and, understands these differences can tell them apart pretty quickly. For example, in epileptic seizure, you rarely have your eyes closed. Your eyes, are, generally speaking, are open. But in non-epileptic seizures, you're much more likely to actually show that your eyes are closed and then resist your eyelids opening. So you're kind of purposefully shutting those, compared to in epileptic seizures where not only are my eyes more likely to be open, but if they're closed and you try and open them up during the seizure, there will be no resistance. Same thing with, things like the light reflex, for example, where you still will have the appropriate light reflex during a psychogenic non-epileptic seizure, but you wouldn't during a epileptic seizure. So there's not just differences there, but there's differences just overall. For example, the length, my limbs moving asynchronously compared to synchronously, how my head moves, falling down and kind of lying still, like all of those things are very, very common in psychogenic non-epileptic seizures, but are very rare in epileptic ones. So this is what I mean by the clinical picture is incompatible with what we typically see in a neurological disorder. There's lots of questions coming in the chat, I see, so feel free to keep up with that and we'll answer the ones that we can. Next, I want to just kind of quickly talk about the etiology of functional neurological disorders, so kind of what causes it. And as with most of our mental health disorders, taking kind of a integrated perspective seems to be much more helpful and useful. So we want to think about not just kind of the biological and neurological contributions, but also your psychological and social and historical contributions. So when we're thinking about, why is this person having this? We're not thinking about only one factor. In other words, we're thinking about Many different factors, including like what's predisposed me to have this, what immediately precipitated it, and then what sort of things are perpetuating it and reinforcing it. So the three P's here. Generally speaking, this seems to be a mix of higher order, so kind of top down and then bottom up influences that are interacting with kind of basic motoric functioning. I think you can see that here in a minute. Here are some of those factors that are likely to come into play. And this isn't to say that everyone who has an FND has to have every one of these, right? But more of like these are things that we found in the research that are really predictive. So having traumatic events or having other kinds of psychiatric symptoms, bodily focused kind of somatic symptoms, exposure to different kinds of illnesses, particularly in your immediate family or in your profession. Symptom monitoring, very high symptom monitoring, so lots of attention paid to your own body and symptoms, and then neurobiological aspects as well. And again, no one of these is likely to cause you to have an FND, but when you start having multiple of these areas kind of coming online and being introduced to your environment, you're much more likely to have that. Predisposing factors, early childhood experiences do seem to be pretty important in FNDs, where you do have much higher amounts of childhood trauma. But that's not most people. So most people still don't meet PTSD criteria. But just having things like, higher childhood ACE scores puts you at risk. There's been a lot of work on genetics and kind of looking at that, and there's some support for a couple of polymorphisms as well as some epigenetic influence, but nothing that's like, this is the gene for FND. We do see some research on kind of internal psychological factors like temperament and then personality. So certain kinds of personality traits, insecure attachment, much more likely to display these FNDs. So those are kind of some of those predisposing factors. And then precipitating and perpetuating factors are something that we really pay attention to because these are things that we could potentially change during treatment, right? And so, we've got a lot of research on both kind of the biology that's being disrupted as well as the psychology, right? So, what is it about me as an individual that's likely to have X or Y problem here? And I know, and all these slides, you guys have them, so I know I'm going through them a little quickly, but I want to get some of the big points. So when we, think about why is someone having these symptoms, right? These motor symptoms, sensory symptoms, cognitive symptoms, we can't only focus on, okay, well, what triggered it, right? We need to think about like, what are the predisposing factors that have then led to things like my level of natural dissociation, my level of stress, my expectations for physical symptoms, my attention to physical symptoms, and what environmental context am I displaying these in? And so putting this all together in kind of an integrated model with your case formulations really does help improve you understanding functional neurological disorder, because what we see all too often is people who are like, well, I'm being told this is all in my head, right? Like I'm just, I'm crazy. It's all in my head because there's no medical reason for it. We want to help them understand like, no. It's not really all in your head. Here's what's going on. In terms of maintenance that we see with these kinds of symptoms, we too tend to see a lot of phobic avoidance of situations. Other particularly, like secondary gain someone may get from displaying these symptoms. Sometimes in, familial situations, you might have somebody being reinforced inadvertently for kind of having this sick role in the family. Um, Certainly because of these symptoms, we see people develop affective issues. And because our brain changes in response to what we do eventually see changes in brain plasticity that could help to maintain these physical symptoms, right? So if I do something over and over again, or I, stop doing something for a very long time, we're going to see those changes that can help maintain this. So the reinforcing factors are something that we work on in treatment a lot, and I just kind of wanted to highlight those. Things like secondary gain I might receive from this, or, what's the attention I'm receiving for this in terms of my role in the family. So those are things that we work on kind of from an external behavioral role. But then we also have cognitive things that we have to work on, like misinterpretation of symptoms and kind of anxiety and expectations, because these all interact with each other for us to be able to say, hey, we need to, intervene here a little bit. So for PNES specifically, I did want to highlight that we have research showing that if someone has this specific type of functional neurological disorder, they're more likely to have actually been exposed to seizures in other people. So kind of seeing that. They're also more likely to have had kind of mild head injuries, not necessarily like full concussion or TBI, but like mild head injuries. Um, but they're also likely to have a history of dissociation, as well as a history of high adverse childhood experiences. So again, any one of those is not necessarily going to, cause you to develop an FND. But when I start putting more and more of those together, my likelihood goes up and up. So I wanted to wrap up my part of today, just talking a little bit about treatment, and kind of what that looks like. And we're going to have a lot more information on specific aspects of that. So I'm not going to go into huge detail. But what I do want to really emphasize is that this tends to be an interdisciplinary treatment, right? So when I'm working with somebody with FND, I'm communicating with typically their neurologist, maybe a physical or a speech therapist or an occupational therapist, potentially depending on where they are, like a personal trainer or an exercise physiologist. So there's a lot that can go into this, because we want to address not just, kind of the psychological factors, but all the other factors too that come into play here. So you might be addressing psychological factors or maybe social factors, but maybe you also need to make sure you're taking care of sleep stuff, and are they having pain and how is that being addressed? And so there's a lot of work that goes into this. And when we talk to and think about this, we really need to be thinking about this as a disorder of software rather than hardware. So, in other words, this is a disorder of function, right, rather than a structural disorder. And one of the big components that we see that can increase success is effectively delivering that idea and having people kind of understand and accept that that's what's going on. So buying into this understanding of the kind of what causes this becomes incredibly important. So it's not like, oh, this is all in your head, just go see a therapist, right? It's like, no, this is a functional problem, that we're probably going to have to address in a number of ways. And psychological treatment is a big part of that. But also, we're going to have some adjunctive treatments, like physical therapy is very important here. Medications are often a very important part of our treatment plan here. especially the longer that they've had these symptoms, the longer it's usually going to take to recover that functioning. So you have to be kind of very supportive and reminding people that like this is going to take time, right? Um, General principles, are I think not too different from any other treatment that we do, right? Like we're going to communicate, here's your diagnosis, here's how it fits within this kind of an integrated framework. Um, we're going to, talk about, what's helpful versus unhelpful. We're going to make sure that your motivation and your hope are both up. And we're going to involve other people in treatment too. So typically that's the family or their caregivers, spouse, et cetera. So those are all pretty general things that we do. Um, Specifically for functional neurological disorder or functional movement disorder, we're really putting an emphasis, and Charles is going to talk more about this, on relearning kind of normal motor control. Um, and that may include things like working on the treadmill or transcranial magnetic stimulation in some extreme cases, but also things like visual feedback, and really focusing on like movement quality, right, rather than quantity. Kind of like when I do physical therapy, right? Like my PT wants me to do quality movements, not just how many did you do, right? Like what's the quality of this? Um, And then with PNES, what we're trying to do is really do things like, avert episodes, um, develop self-management plans, challenging safety behavior or avoidance behavior that people have. And, that's different than you would treat a lot of other problems that were, truly neurological. So our framework then is typically a cognitive behavioral framework. Um, and what we're really focusing on is like, what are the factors that maintain your problems currently, right? Like we're not thinking about the past, we're not worried about that. But currently, what does that look like? Um, and so lots of psychoeducation, just like we do in any good CBT, learning to kind of gain control of your symptoms, recognizing what are the triggers for these, working on cognitive and behavioral shifts, and then also improving interpersonal functioning is a big, big important aspect here in CBT for FNDs overall. Um, Target wise, these are going to look pretty similar to most of your cognitive behavioral work, challenging unhelpful thinking. So using cognitive restructuring, kind of learning how to reattribute the symptoms I'm experiencing to psychological and psychosocial issues. Much like we see in like panic disorder, like I'm learning how to accept panic, but not going to a full panic attack. Um, and then addressing things like external locus of control versus internal, or like what are my expectations for different kinds of symptoms. Um, Again, not too far off from what we see in a lot. And then for behavioral targets, we're really often targeting stress. And then depending upon the particular kind of symptom, we might be developing habit reversal responses for a functional tic disorder, or essential tremors. We might be focusing on avoidance and escape behaviors for people who are having that as a maintenance factor, but then also just reducing stress generally. And the outcome research is actually quite good, particularly when you compare it to no treatment or other kinds of treatment. We see both physical and psychological improvements, much better for cognitive behavioral therapy than for our head-to-head studies with different kinds of psychodynamic therapies, both in immediate and then follow-up. And with PNES specifically, we see lots and lots of decrease in seizure frequency. The largest meta-analysis I could find showed that about half of our patients were seizure-free. And then over 80% had a 50% or more decrease, which was huge. But like I mentioned earlier, a big predictor of improvement is that explanation of symptoms prior to treatment and understanding and accepting that. So that was a lot. I know that I threw at you, especially if you're not too familiar with this. I see that there are approximately 1 bajillion questions in the chat, which is also fine. Um, it may be more useful to kind of address some of those as we go or save them for the end, since it's already 12:55. Um,
I was copying and paste them, Caleb, into a document. So the first one that came in was for it to be FND, do the symptoms typically appear bilaterally, meaning blindness in both eyes or paralysis in both legs, or can it vary?
so that's a great question. So I think it's more typical to be bilateral. I have seen folks that it was not bilateral though. So where it was like one limb versus like one arm versus the other, or tremoring in only one limb versus the other. So it's more typical, but that's in and of itself not just a rule out symptom where it's like, oh, it's in both limbs, it's not neurological, right? Or it is neurological.
Somebody had asked for a neurologist, and Dr. Myers put a link in there for you guys. So I'll grab that link so you can have some neurology referrals if you would like. Another question here, Caleb, is there a minimum duration for occurrence for an acute episode?
That's a good question. So, unlike most of our like DSM disorders, there is not a specified minimum. There's a specifier for if it's more or less than 6 months, but there's not like for depression where it's like, oh, for 2 weeks you have to have this or that. There's not that for the conversion disorder in the DSM. Partially that's because we know that the earlier intervention is crucial. So you don't want to just kind of like poo poo and be like, oh, come back and see me in another 6 months. Right. It's like, no, no, no. If you're having these problems, we need to get on top of these as quickly as we can.
And anything about diagnosis in children, minimum age, different presentations, anything you can comment on there?
So, in terms of diagnostic criteria, there's not like differential diagnostic criteria for children versus adults. Um, Seeing this in children, meaning prepubertal, is pretty rare, though. I mean, it's rare generally, but prepubertal is pretty rare. You're more likely to see these postpubertal, and then as adults.
We have time just for a couple of more here, Caleb, if you've got some bandwidth for us.
Yeah, of course.
Curious about the overlap with PANS pandus. Is PANS pandus considered a medical cause of neurological symptoms or a part of a predisposing factor for developing FND?
Yeah, that's a good question. So if you have a like a PANS or a PANDAS diagnosis, that would point to a medical or neurological condition, right? Which would actually be a rule out for a diagnosis of functional neurological disorder. Um, so that would kind of automatically say, no, you're having this because of, say, pandas, right? As opposed to like, we'd have no idea why you're having this. Certainly some of the factors are similar, like the rapid onset that often happens, certain kinds of symptoms that you could have. But if you're saying like, no, this is a PANS or a PANDAS issue, then it would not be.
And then the last one here, similar to this and Ehlers-Danlos syndrome, would these disqualify an FND diagnosis since they would be seen as medical explanations? Or is there no way to prove it as the origin of the FND-like symptoms? Did we lose Dr. Lack? I think we just did. Totally froze on us. Um, I don't know if any of the other presenters want to give a crack at that question. If not, that's
I can
okay. I will save it and we can put it at the end of our talk.
I can say something. Although I think it's convenient that Caleb froze right at that really hard question. Um, I think it'd be very hard to rule out um, a lot of people have a real a organic neurologic disorder and then also develop functional symptoms on top of that. So it's not uncommon to see people with epilepsy have non epileptic sort of functional seizures as well, or people with tics can have functional tics as well. So having a neurologic disorder or any disorder doesn't rule out also having functional disorder. I think you'd want to see that there were different qualities to the episodes that weren't consistent with what you normally see in an organic disorder.
That's fantastic. Thank you, Dr. Jeremy. All right, you guys, we are going to move on now to our second talk with Dr. Charles Gallion. I will not forget to introduce him as I did Dr. Lack, so my apologies, Dr. Lack. Um, Charles is a licensed psychologist currently working at the Knoxville Behavioral and Mental Health Services in Knoxville, Tennessee, where he specializes in childhood behavior and developmental concerns. Dr. Gallion has extensive training in assessment of childhood disorders and behavioral interventions, including areas such as training in ACT, SPACE, ERP for OCD, and comprehensive behavioral intervention for tics and habit reversal training for Tourette's and tic disorders. Much of his work has focused on empowering parents to tackle various challenges in parenting, including managing challenging behaviors and parental stress, with the goal of enabling parents to respond to and be with their children in the way they wish to be. Charles, it's a real pleasure to have you here. Thank you very much. And I'll turn the Zoom over to you.
All right. Thank you, David. Let me see. I'm going to pull up my slides for you guys. I wish I would. Okay. I mean, it does this, but I just, That's showing you like my entire screen, isn't it? So now you can just see all my tasks. That's not cool. Let's try it. Is it fighting me? I think it is. I'm going to go over here, play from start. And now if I do this and I say, there, is that working?
That's great.
Okay. It doesn't show me my notes, but that's better than it was. Okay. There are some things I want to try to talk about and make sure to talk about. So I include those within my notes, but at the moment it does not seem to be allowing me to see those. But